This is a wonderful question, and there has been a great deal of activity in both of those areas, and much of this was presented at the recently concluded TLMDX, or our liver meeting digital experience. Let's start perhaps with hepatitis B infection, where the whole idea, as you've suggested, is that if we can accomplish cure for hepatitis C, what's to keep us from doing that for hepatitis B? Now, they're two very different viruses. They do infect the same organ, the liver, of course, but they have very different life cycles and very different behaviors. And hepatitis B in particular is a much more persistent infection because of its ability to reside in the nucleus of the infected cell as a very stable form. And so cure of hepatitis B infection is much more challenging to accomplish. But having seen the success we have had with DAAs, as you pointed out, for hepatitis C, has really stimulated all of us in the field to look at more energized approaches to treating hepatitis B. And in this regard, there has been lots of activity in the development of agents that work against multiple targets of the hepatitis B virus, directed typically at one target, an enzyme that the virus produced known as the HBV polymerase. We've now seen that, given the complex life cycle that hepatitis B has had, we've now seen several other mechanisms or agents with differing mechanisms of action working on different steps and new steps in the virus life cycle. So examples of that include so-called capsid assembly modifiers, or capsid inhibitors. There are several of these that have had data presented at this meeting and others, which demonstrate that they have an antiviral effect against hepatitis B replication, and they also appear to diminish formation or assembly of the virus as well, and may have impact on the ability of that highly stable form of HBV in the nucleus of the infected cell to be transcribed and translated. So in this regard, they offer additional activity against Hep B that inhibitors of the polymerase, which a number of which are FDA approved, don't do. And so there is the belief here that we will demonstrate additive effects, if not more than additive effects, of these agents with currently available treatments. There was also excitement around other mechanisms of action, inhibitors of what we call the RNA that comes out of the nucleus that becomes transcribed and that becomes ultimately translated into viral proteins, can now be bound to and blocked by a number of different strategies, one of which is called RNA interference, or RNAi, and another of which is called antisense oligonucleotides. Both of these, in essence, are sequences that are specific to the hepatitis B virus RNA coming out of the nucleus. And these are delivered to the cell using targeted approaches. They get taken up in the cell, and then they bind these sequences and knock down production of the viral proteins. And so we saw some exciting data that supported the idea that these RNAis can not only engage their targets, but do so in a very prolonged manner and knock down protein synthesis for a very prolonged period of time. And this offers encouragement for us to believe that ultimately we may achieve this strategy, combined with other strategies, offers us hope that we may be able to see enhanced rates of functional cure, namely the loss of hepatitis B surface antigen in patients who are chronically infected. So there's a lot of excitement around these new classes of therapy and how they might be used in combination with one another to bring about increased rates of functional cure, which right now are very low on currently available treatments for hepatitis B. Similarly, in the fatty liver space, or the non-alcoholic steatohepatitis or NASH space, there has been a great deal of activity for different inhibitors of different targets that contribute to the development of fatty liver inflammation and fibrosis that are characteristic of NASH. These are inhibitors across a whole variety of mechanisms, and we're excited to see that several of them show considerable promise for their ability to reduce liver fat, their ability to reduce liver inflammation, their ability to resolve NASH itself, and their ability to improve fibrosis. And additional benefits for some of these agents may actually lie in their ability to improve weight by reducing weight in some patients, or many patients for that matter. We've also seen the ability for blood sugars and insulin resistance to improve, and even serum lipids move in a favorable direction in some of these instances. So there are reasons to believe that some of these compounds will emerge as successful strategies for a condition that affects such a large portion of the population, and for which there are no approved therapies as of yet. So these include treatments that would work on a variety of different mechanisms. They include agonists of fibroblast growth factor 19, fibroblast growth factor 21, PPAR, another target, are all involved in the generation of fat in the liver, or lipogenesis. In another class of therapy that was introduced at this meeting is a fatty acid synthase inhibitor. Once again, an enzyme involved in the production of fatty acids in the liver, all of which produced really encouraging results for improvements in the hallmarks of NASH. There have been improvements as well in agents that work on blood sugar or glucose handling and insulin resistance, and induce weight loss, which is such a problem for most of our patients with NASH who are overweight or obese. These include agonists of glucagon-like peptide 1 or GLP-1, which have shown their ability to improve NASH and bring about, in some cases, significant weight loss. And there are also inhibitors of a separate protein called SGLT2, which is involved in the transport of glucose. And these can be seen or have been used in diabetic patients, and have been shown to also produce beneficial effects in fatty liver. So collectively speaking, with all of these classes having had data presented at this meeting, we're very excited about the idea of these agents targeting host metabolism, bringing about improvements in the key features of fatty liver disease. So there is a great deal of excitement about the prospects for these agents moving forward deeper into clinical trials, and ultimately having some fraction of them approved ultimately for treatment of our patients. Yes, this has been a huge issue for care providers all over the world. And in many ways, what COVID has done has been to accelerate or to turbocharge the integration of telemedicine into practice. You know, video conferencing and teleconferencing had certainly existed before COVID came, but COVID really dramatically accelerated the integration of this technology into practice. So much so, I think that I think what we've all come to learn is that there is a subset of our patients who may very well benefit from continuing long after COVID is solved, or has an effective vaccine, and it's safe for patients to be coming back to the hospital or to the clinic, there will still be some patients for whom telemedicine will continue to be practiced because of a variety of circumstances, not the least of which would be logistics of getting in to the medical center for care. So we've already seen, I think, some important changes occur that will affect our delivery of care moving forward. Other ways of coping with COVID using telemedicine has been, video conferencing has allowed us to check in with our patients and to get a look as to how they may be faring, and may allow us to triage them to come in for more direct face-to-face care if needed. But what we have also done is, particularly for academic medical centers, where again patients may have challenges making it in from remote distances, is to use local resources, local laboratories, local radiology, for instance, to minimize their trips to the larger medical center. And this can, again, help not just decompress or decongest the traffic in the medical center, but allow patients to have enhanced convenience and with regard to getting the care that they need. I think another important aspect of COVID and telemedicine that will impact care moving forward is the idea of using, again, telemedicine, not just to deliver care directly to our patients, but as well to deliver care and advice to other providers. And so here again, the academic medical center, which may be the hub of knowledge about specific conditions, can be used as a resource to train primary care physicians who are seeing those patients on the front lines to care for those patients and learn essentially the tenets of the care of conditions like hepatitis C or hepatitis B or non-alcoholic fatty liver disease. And so in this regard, we can multiply the effectiveness of the workforce that does exist. And then this is particularly, again, effective in far-flung or more rural areas where, again, those patients may not be able to make it in to the center and for whom they may be seeking care much more locally. So I think what COVID has done and will do is to accelerate the rollout and integration of these train the treater models, where we may be able to multiply the workforce, as it were, for the care of these. Not replace, of course, the need for face-to-face visits for our most sick patients, many of whom have advanced liver disease. They will need and continue to require, at a minimum, periodic face-to-face visits, and certainly at a maximum continued face-to-face care. A really important question. Are our patients with advanced liver disease more susceptible to COVID-19 and more susceptible to mortality attributable to COVID-19? And there are a number of studies that have looked at this, and certainly, again, presentations at this meeting did address that. And the one presentation I think that you're referring to was very provocative in that there were three major risk factors among patients who had cirrhosis that appeared to put those patients at higher risk for mortality when contracting COVID-19. The first was the presence of decompensated liver disease. In other words, cirrhosis that was not stable with regard to the preservation of hepatic function, but there had been loss of hepatic function, or the development of significant portal hypertension that was clinically met. In these individuals, when those individuals contracted COVID-19. A second risk An independent risk was patients having hepatocellular carcinoma or liver cancer. And it appeared that this risk was independent of the first risk I described of having decompensated cirrhosis. So that even if you had hepatocellular carcinoma and did not have decompensated liver disease, there appeared to be an increased risk. Whether this was related to the cancer itself or to its treatment remains to be seen and deserves further analysis. A third independent risk factor appeared to be alcoholic liver disease. So in particular, among all the causes of cirrhosis, it was alcoholic liver disease and alcoholic cirrhosis that appeared to be, again, an increased risk for worse outcomes with contraction of COVID-19. Again, the specific basis or explanation for why that should confer a higher mortality was not clear from the analysis of these data. But I think it was reasonable to speculate, as the authors did, that perhaps alcoholic liver disease is accompanied by significant derangements in inflammatory cytokines that we know are significantly deranged in COVID-19 disease. So could it be that there might be enhanced inflammatory profiles in these patients that are stirred up further with the contraction of COVID-19? Again, further work would be necessary to try to tease that out. So these are highly, again, provocative findings, and again, with longer-term follow-up and larger studies, it will be important for us to learn more. But needless to say, I think those patients who have advanced liver disease in the form of decompensated liver disease, we need to take great care of with regard to minimizing their exposure to COVID-19 wherever possible.